Welcome to Beyond the Clinic. I'm Harold Pan, physical therapist. Today I want to talk about something that happened yesterday with regards to patient care. No, it's not nothing that happened in particular with my patient, but a realization that I had. And I've been told this many times. Your mentors, they tell you things, and you it kind of registers, but it kind of doesn't until you start working. So I've kind of done a little bit of everything. I've done outpatient. I've done rounds on acute and in inpatient rehab. I haven't quite done the sniff thing yet, but I've done mobile therapy, and I'm really getting into the home health arena now. And I am pissed. One, school doesn't teach you anything about how to do an OASIS documentation or what it values. It tells you documentation is important. It's important to CYA, cover your ass. Yes, it's important. But what it doesn't tell you, and what Brandon Smith told me, and it took me a while to register, is that EMRs are glorified cash registers. And that's rings true for outpatient, inpatient, home health, anywhere. That's what an EMR is. Ray Berardinelli also says this too. EMRs suck. What does it do? I'm going to drop a little bit of knowledge for you today. You type in codes. You register codes, ICD-10 codes that match a patient to a diagnostic or multiple diagnostics to determine the complexity of the patient and his or her care. And that drives the reimbursement. Now, therapists, the one-to-one providers, they get paid an X amount per visit. Doesn't matter how complex it is. But what you end up billing in your documentation, that's what justifies it. So why is it that you get paid anywhere between $60 a visit, maybe even $43 a visit in some states, to up to maybe 120, maybe if generous 180, if you're really advocating for yourself? Why is it that you get paid that much, but each visit gets billed like $300 to $500, and somehow the patient doesn't really see the bill? It's because of the insurance game, and our healthcare system is broken. My God. I don't know how much you pay in health insurance, but for 3 people in my family, myself, my wife, and little baby William, I'm paying close to $1,600 every month. And no, I don't have Medicare, but it's a pretty good insurance. And the funny thing is, I don't get to see who I want to see. I still somehow get letters of the EOB explanation of benefits that say I'm not covered, or this doctor doesn't take my insurance, or that doctor doesn't take my insurance. I thought I took the best PPO, or one of the best PPOs, and somehow I still don't have a say in who's in my network, who's out of network. This is why I initially went to mobile practice, and this is why I'm going to continue to go mobile practice. I'll tell you what happens. Kinzer Wellsky, that's one of the best home health EMRs on the market right now. We're well known and sought after for a lot of agencies, and they have their strengths. When you get a referral from the doctor and a patient's discharged, they send you a PDF. They send you multiple PDFs and upload it to the system. And when you do a start of care OASIS, outcomes assessment information set, to really, like, they say it's for documentation and reviewing systems, but honestly, the patient just got discharged from the hospital. They did review of systems there. They have all the diagnostics. And yes, when you do this documentation, okay, I'm gonna go on a tangent right now. So, either clinicians are well trained to do this and can do it efficiently with full understanding, and the school prepares them for it, or they're not. Yet clinicians are sent out to do it anyway. to drive some sort of reimbursement. Which one is it? What do you want to do? Pick one, but make it consistent. So schools, they got to prepare you, and programs got to prepare you. Agencies got to onboard you properly. You don't do the training after you see the patient. You do the training before you see the patient. Some agencies do good at this, some agencies don't. Or you learn it all just trial by fire, which is incredibly hard. Or just don't have clinicians do that much of a thorough oasis. No, I might be stepping on some toes on here. I might be pissing some people off. Maybe pissing off Medicare. Maybe pissing off home health agencies. Or clinicians in home health. But you get a 35-page referral packet from your doctor with duplicate information sets, yet there are little changes between each one from each one session to the next, from hospital intake to reassessment to discharge, and you have so many information sets with multiple diagnoses and multiple comorbidities, secondary diagnoses, past medical histories, past surgical histories, medications lists, etc., etc., etc. And this is one of the good documentation softwares. You could be doing home care, home base. You could be doing Devero. Those kind of suck. And somehow you still have to pore over when you go onto the Kinzer WellSky interface and you type in the diagnosis. You actually have to get it right and list every pertinent diagnosis. And the patient might have like 30. Probably not 30, maybe somewhere between 3 to 13. And it's a lot still, because that's just one page out of like 18 pages of the OASIS. And it's not enough to type in neck pain, multiple rib fracture, perioperative stroke, etc. What you type into the box has to correspond exactly verbatim to an ICD-10 code. Otherwise, it will not register, and it will be an invalid OASIS. I swear to God, and I know I'm kind of new to this game here, but last night when I was doing an OASIS start of care for a patient, it took me at least 5 minutes to scroll through every damn diagnosis when I was typing up for like a stroke on the right side of the brain and a hemiparesis, and the list of diagnostics was long, and you had to do it for the inpatient diagnostics that were treated in facility, and you had to do it for the diagnostics that the patient had afterwards, and then the secondary diagnostics, not to mention the medications and entering every single medication. Okay, this is the life you chose, this is the bed you made, so you got to sleep in it. I get that. That's part of your responsibility. That's your charge as a healthcare provider. But tell me this. How much is going to change between 3 days without anyone being seen? How hard is it for there to be a uniform system where information gets translated from one set to the other without putting the burden on a clinician to individually type each one? That doesn't take a doctoral skill set. That takes a copy and paste skill set. Okay, that rant is kind of, I'm kind of over that rant here. Well, what I'm saying is, if this is really important, why isn't there a greater value placed on getting this accurately done? Or is it even that important? Is it only important so that there's a reimbursement? And why is it? Is it the home health agency's fault? They got to get paid, right? They got to be able to pay their clinicians. So yeah, they have to follow the paperwork to submit appropriately to Medicare. Is it the patient's fault for opting into insurance? No, Obamacare, it kind of drives this incentive to get insurance. You have to, otherwise you're penalized. But it kind of sucks because not many people opted into the right plans here. Is it our fault as clinicians for doing a crappy job? No, we're getting pinched. Is it Medicare's fault for PDGM, PDPM? Some say yes, some say no. Maybe, maybe not. Maybe there has been overutilization, overbilling, fraud. This is why I do the mindset talks. This is why I talk about what it takes to be a clinician. Are you checking your vital signs? Are your personal vital signs? Are you being fit, financially fit? Are you being are you giving yourself your individual spirituality? Are you doing a time audit? Because those things factor into your mindset when you go out to see patients, when you document and understand the value and importance, and when you train. That's why. That's why I think it's really important to have a mentor to help you see through these things, because like I'm only a couple weeks into working again after a whole year of pandemic and childcare and all these new challenges, and honestly like the system sucks. It sucks. So many people say, oh, do home health, you have flexibility, you get paid more. For how much work you put in, I don't know. I don't think so. You're better off doing your own thing. Up to you, up to you. But you got to do your part in fixing things up if you want it better for the future. If you want to care about patient care, if you want to care about your colleagues and your cohorts, if you want to care about the future of the profession, you got to do better. You got to start setting things in stone and setting a pathway. You have the knowledge. I'll argue that I know so much on how to rehab a patient, give them what they need, but I'd much rather be finding directly what that is and coaching them and telling them, look, this is going to take a long time. You're complaining of a chronic stroke to me when you're recently discharged for a different reason, and I don't want to spend 45 minutes explaining why insurance isn't going to cover a chronic condition for an acute thing that you've been discharged with. I want to just treat your problem and help you out. And I could do a better job of explaining that if I didn't have to jump through all these loopholes and red tape. Treat what you can within the system. That's why we buy insurance. But don't be afraid to opt out. Don't be afraid to step outside the box and actually use what you know, use your strengths, use your passion. Because for every home visit that I do, I find myself using maybe at best 25% of my PT skills to actually do PT with my patients. This other 75% is all bullshit paperwork. That's my angry rant. I hope you took away something from this besides me being angry. I hope you have some sort of incentive. I hope this lights a fire under your ass to get moving, to go forward, to not be a slave to your debt, to the healthcare system, to actually start to make your own way. There are ways to do it. I'm not the greatest coach to teach you how to start a mobile practice or brick and mortar practice, but I know people who can do that. And there's so many people they've coached through this. I know people that are coaching people through PT school. There's so many things you can do as a new clinician or veteran clinician who's getting sick and tired of this. But what you shouldn't be doing is checking your documentation and just hoping and praying to God that you don't get any more patients for the day. Because that's not serving anyone, not serving you, your patients, or anyone else. Thanks, have a nice day. Please leave me feedback. If you enjoyed this content, if you want to hear more, please like and subscribe below. Thank you.